Hi, this is James Lee with the First Committee here at SCCT 2016. I'm here with Kelley Branch to chat about his thoughts on the meeting here so far. Kelley, what are you looking forward to most at this meeting?
Well, I've always enjoyed the SCCT just because there's really so much to learn. I am looking forward to some of the emerging technologies and, of course, some of the applications of these emerging technologies, especially when it comes to structural heart disease, as we're moving more towards more valve-in-valve and really moving away towards replacement of the valve rather than implantation of the valves.
Great.
Also looking forward to a lot of the applications of plaque morphology as it relates to acute coronary syndrome and risk, and then finally the application of really some of the new guidelines, and that is the CAD-RADS guidelines.
Oh, that's great that you bring that up. We're actually really interested in what your thoughts are about the CAD-RADS guidelines.
Well, I think it's very, very helpful. It's been a little bit of a emerging application towards patients. In other words, how do we approach the patient with the small stenosis, the 0 to 50% stenosis? How are we supposed to treat those patients? Should we be treating those patients differently? We know that from prognosis, obviously those patients should be more towards a secondary type prevention rather than a primary prevention, more statin, more aspirin, just because of the higher risk of observable atherosclerosis. And this concept is going to be translated by the CAD-RADS to say that we need to treat these patients or approach these patients a little bit differently. In addition, those patients with the intermediate lesions, the 50 to 70% lesions, do they all need to go to the angiographic laboratory, or could we possibly take those patients to stress testing first? And so these guidelines will really help us in order to conceptualize the patient in a different way based on what we're seeing with plaque morphology.
I think it's really exciting in terms of trying to standardize patient care, and I look forward to seeing where that goes.
Absolutely.
Being one of the leaders in CT perfusion, how do you see the future of CT perfusion going on forward here?
Well, I think that there's a lot. I think CT perfusion, even though we do have a lot of smaller studies, a couple of multi-center studies, but it's still overall is really kind of in its infancy. Really, where cardiac CT was after the first iterations, heading more towards kind of the 64 slice era. I think over time that we're going to be refining our protocols. We're going to be using the larger, wider bore detectors, so single rotation, single heart, and then trying to figure out, do we need to use dynamic imaging, and that is where we're taking repeated measures, or do we just do a single shot, and is that good enough? But I really see that the melding of not only morphology and physiology, putting those two together, I think is going to be much more helpful, and I think will revolutionize how we approach patient care.
Great. Well, what do you think is the main barrier for the integration of CT perfusion in clinical practice?
I think it's like most technologies. It looks very attractive, but until we actually show very robust data in a multi-center way, and then really translating towards prognosis to really show that we are adding value, not just adding a scan, that's really going to be the biggest barrier. Once that happens, then we can start to look towards implementation, and implementation will also be insurance coverage, because if you don't get paid for it, it's not really going to happen.
Well, thank you so much for your time. This is James Lee and Dr. Kelley Branch here at SCCT 2016.